All right, everybody, welcome to the voiceover for urinary system. This is the anatomy and physiology and concept section. This won't be very ridiculously long, but I wanted you to be able to come back here and have a resource if you needed any of the concepts refined to you. We are learning about each body system in detail this time around in block 3, so you'll be able to tell all the different detailed problems in each body system. And then in block 4, we're going to bring them all together into how they work together as a whole. But you can see that the kidneys are actually pretty important. In just reviewing the anatomy, the kidneys are our workhorse. The rest of it is tubes and storage facilities. The kidney is the one doing all of the work here. The rest of it's just drainage. So the ureters are, we'll talk about the kidneys in detail because that's our workhorse. The first drainage hose basically is the ureter, which goes from the kidney to the bladder. Really not much about the ureters themselves. The ureters technically go from the renal pelvis, which the renal pelvis itself, and that will come into play and when we talk about nephrostomy tubes, the renal pelvis itself is the let me get my little drawing thing here. This is the renal pelvis itself. You can see all those tubules. We have tons of tubules in here, all drain into this area, but it only holds 3 to 5 cc's. So basically a 5 cc syringe is all that renal pelvis can hold. So in order to prevent kidney damage, urine has to get out of the kidney as soon as it's made, basically. So as soon as that kidney has made urine, it needs to drain out of the kidney through the ureter into the bladder, and the bladder is where you can hold it. You cannot hold urine in the kidney. It will damage the kidney holding urine in there. So that's really the only important thing about the ureters. It needs to be kept open. The bladder is our storage area until we can deal with our urine. And basically it can hold up to about 250 milliliters before it's like, hey, dude, you got to go to the bathroom. And then it can wait for a little while. Once you start to get about 500 milliliters in that bladder, it starts to become uncomfortable. Like, okay, I really got to go find the bathroom in the next 15, 20 minutes because this is getting uncomfortable. This is where if you're driving along, 200 to 250 is like, oh, maybe at the next exit I'll think about going to the bathroom. At about 500, if you haven't seen the exit, it starts to become a priority to find an exit. It's getting really uncomfortable down there. You really got to pee. Kidney still keeps making urine, keeps dumping stuff into the bladder. As the bladder starts to get up on 800 milliliters or so, you're hitting your capacity. This is where you might start to leak if you haven't found your exit off the highway yet, and you really are starting to think about the only thing you can think about is going to the bathroom. Bladder capacity, the signals are coming so strong and furious from the bladder to your brain that it kind of takes over all of your thinking. Just something I find kind of interesting. Not testable, but interesting. Urethra is from the bladder to the outsource of the, or to the outflow. Women's urethras are much shorter than men's urethras, goes without saying. Let's talk about the kidneys and what they do. And the reason we talk about the kidneys and what they do is so you know what happens when they break. You know what's going to be broken. Number 1, waste excretion. So basically they have 6 jobs. They're all very important jobs, and we kind of have a slide on each of their jobs there. Waste excretion, again, not testable, but I think you need to understand the concepts, because if you do, you will understand our signs and symptoms and our rationales and why we do what we do much more clearly. I just like to show you the kidney. We probably have hundreds of thousands of nephrons. In fact, let me just Google that right now while I'm here. So Dr. Google here says that over 1 million nephrons in each kidney. So we're talking about 2 million of these little buddies. I will tell you that that is an overproduction. We do lose nephrons as we go through our life. And of the 2 million, we probably only need about 200,000 to really do the job. So a lot of duplication of effort here. We really don't need everything, but then as we get older and things die off, kidney function gets a little bit weaker and weaker, and we start relying on the few nephrons that are left. We do not see signs and symptoms of any kidney disease until we're down to, after 2 million of them, we can lose down to about 200,000 of them before we start seeing kidney signs and symptoms. So, like I said, we've got a lot of duplication of effort going on. What happens when we make urine is basically the blood carries everything through the kidneys. It splits off into 2 million different pathways, and each kidney tubule takes care of cleaning out some of the blood. So basically it's dividing up all of our blood into 2 million different pathways, and each little pathway takes a little bit of our blood and cleans it out. So what's happening here is that blood will surround the tubule all the way until it gets to the end of the tubule, and then the blood goes back into the renal vein to go to the rest of the system. So we're carrying around dirty blood, basically. Blood's always being used in our body to, carry products around. It's basically like an interstate. And so basically the bus is carrying a whole bunch of junk in it. It has a couple of different stops along this tubule. So let's look and see what happens here. So we get into the glomerulus. That is the first stop. So the first stop is this little glomerulus. Let me see if I can draw. This is the glomerulus here. This is where all of this filtering is actually happen. And what happens is at this filter, everything gets pushed off the bus, and this is like cleaning up your room or cleaning out closets. Sometimes it's easier to just rip everything out of the closet and put back what you need. It's kind of what the body does on a minute-by-minute basis as blood passes through these glomerulus, is everything gets off the bus and goes into the filtrate. Filtrate's what's going to turn into urine. So as it goes through this tubule, let me just go back again. This filtrate bus stays in the tubule. You can see that urine and blood never mix. They are crossing across a membrane. So think of that white thing that's in between the blood and the tubule as a membrane. And the blood and the urine never touch, but they pass things back and forth to each other across that membrane. And that is our filter. Each nephron is a piece of a giant filter, 2 million folds in this filter, basically. So we've got blood pushing everything out. So basically, I don't want any of it. I don't want any of it. Just push it all out into urine. So all of this will get dumped out into urine unless it gets pulled back into the blood. So everything gets pushed out, and right there in the glomerulus, right after it pushes it out, the blood's like, oh, wait a minute. We've got stuff. So we need a blood pressure of at least 90 for everything to get off the bus and get into the filtrate. And then reabsorption starts to happen. The blood decides, you know what, we need all of these basic building blocks for life. We got to have our glucose and our proteins back. Those are building blocks for everything that our cells do, for making energy, everything that we need. All that gets back on the bus. So right there in that proximal tubule, right after the glomerulus, is where we reabsorb proteins and glucose. Everything gets added back onto the bus. We are 80% water, so the body's like, you know what, we're going to keep 80% of our water. Everything gets back on the bus, and then we get probably about 80% of our electrolytes get back on the bus as well. Those are all things that we need. Things we don't need: urea, creatinine. These are byproducts of cellular metabolism, and they are acidic, and they need to go. They are toxic, and they are waste products, and they need to get out. Any other waste products that we might have, extra electrolytes, bicarb, water, all that's kind of hanging out in the filtrate, and the blood keeps moving. Moves to the next stop, where the loop of Henle, it goes down and around that little loop, and this is where aldosterone, which is a chemical we're going to talk about. If aldosterone exists, it opens up channels for water and sodium to get back into the blood. If aldosterone is not there, water and sodium stay on the bus. So this is where we get to regulate our water and sodium balance in the loop of Henle. As the bus keeps going, the next area is the distal tubule, and this is where antidiuretic hormone, this is the brain gets to have a say, and our acid-base balance is getting so the brain can say, dude, I'm dry up here, hold on to more water. It opens up channels for water to get back onto the blood bus, out of the urine bus. If the brain is like, dude, I'm swimming up here. We got way too much water. Then water will stay in the urine bus and not come back into the blood. The brain gets to have a say here on the antidiuretic hormone. And then the acid base, the kidney has sensors along this tubule to sense whether it's acidic, whether it's basic, and it will hold on to ions and electrolytes and bicarb as needed to keep everything balanced out. After all this, after this last chance corral here, what's left on the bus goes back, what's left on the red bus goes back to circulation and is used throughout the body. Anything that is left on the urine bus at this point now comes out in your pee. So whatever is in your pee is what the body has decided it didn't need, or is stuff that shouldn't have gotten dumped, but because there was damage somewhere along the line, got dumped mistakenly. So that's basically how we make our waste, is everything gets off the bus, and then we suck things back up into the blood that we need. All the unneeded stuff stays in the urine. So that's kidney job number 1. That's the one we all know about. It makes pee. Kidney job number 2, and actually one of its biggest jobs, is helping us regulate our blood pressure. We have a couple of different mechanisms for regulating the blood pressure, but one of the big ones is this renin-angiotensin-aldosterone system. So the kidneys, when they sense that they are not getting that 90 systolic blood pressure, or their pressure that they need to get everything off the bus to filter, they send out something called renin. Renin is the only thing that the kidneys secrete. Renin then goes into the bloodstream and gets converted in the bloodstream to these other forms. Angiotensin is a vasoconstrictor. So anything, if you want to, this is, again, background knowledge. Renin, angiotensin, aldosterone increase blood pressure. So when there's decreased perfusion, it will increase your blood pressure. And it does this by making angiotensin, which is a vasoconstrictor, and aldosterone, which tells the kidney to retain water and sodium, which will make your blood volume go up. So increased fluid plus vasoconstriction gives you increased blood pressure. This is a great idea unless the kidney is doing it because it's broken. Sometimes broken kidney glomeruli will secrete renin wrongly when we don't want increased vasoconstriction and blood pressure. So there are 2 blood pressure meds that work against this system, and I will give you a second to remember them, but they are our ACE inhibitors and our ARBs. These 2 blood pressure meds, or the classes of blood pressure meds, those 2 blood pressure meds work here. And what they do is they inhibit this process. So ACE inhibitors, what are they going to do? They're going to stop that process. Everything downstream stops happening. No more vasoconstriction, no more retaining water and sodium. So ACE inhibitors and ARBs, angiotensin receptor blockers, both of them work differently, but they stop vasoconstriction, meaning that your blood pressure doesn't get tighter or higher, and it stops retaining water and sodium. So guess what? You will pee out water and sodium. So ACE inhibitors block this blood pressure system. Very important when we start talking about heart failure later on and fluid. But that is a very important concept, that renin, angiotensin, aldosterone is involved in blood pressure management. That's just another picture of the renin, angiotensin, aldosterone system, and you like complicated pictures. There is something called prostaglandins. Every yin has to have a yang. If we can increase blood pressure, the kidneys can also decrease blood pressure by secreting these prostaglandins. And prostaglandins do the opposite. They can decrease pressure in the glomerulus. So if the pressure is too high, let's say your blood pressure is 200 over 110, that is too much pressure pushing against that delicate little glomerulus. It can break filter membranes. And so the kidney will secrete prostaglandins to save itself. And it will also, if there's so much pressure, the kidney will send out these prostaglandins to cause kind of a diuretic thing. Like, there's too much pressure here, man. Let's get rid of some of this extra water and stuff like that. But anyway, the only interesting thing I find about prostaglandins is that's why non-steroidal anti-inflammatories, we always hear are kidney toxic. And that's because they block prostaglandins. Oops. So if you're blocking prostaglandins and you have a high blood pressure, nonsteroidals will block the kidney self-protection process going on. So nonsteroidals aren't directly toxic to the kidneys. They block prostaglandins. So I think that's interesting too. The kidney job number 3 is part of fluid balance. So, it goes along with the waste excretion, but it listens to the brain. The brain's the big kahuna up there. And if the brain tells the kidney to do something, it's going to do it, whether it thinks it's the right thing to do or not. So antidiuretic hormone will tell the kidney, don't hold on. Antidiuretic hormone is don't pee hormone. So if the brain sends out a message saying don't pee, the kidney's going to hold on to fluid, whether it likes it or not. The brain's the big boss. So if the brain says don't pee, the kidney won't. It'll hold on to all the water. And if the brain says, dude, just there's no antidiuretic, I'm not telling you not to pee, just do whatever you will, then the kidney will put out water. This will be important later on when we talk about SIADH and diabetes insipidus. But for now, just know that the kidney does listen to the brain, and the brain will send out antidiuretic hormone to help balance fluid. The other job is, of course, one of its big, important jobs, right behind waste excretion and blood pressure management, is acid-base balance management. And this is our metabolic component. The kidney is slow to react. It takes a couple hours to start balancing things out. But when it detects a high blood acids, or say a high pH, an alkalotic state, it's going to dump bicarb and reabsorb hydrogen ions, going to make the body more acidic. It's going to try and balance. It's very sensitive to that 735, 745 number, and it will hold on to whatever it needs to get everything balanced out. So it's involved in balancing our metabolic side, and it's involved in controlling bicarbonate. And so if your body is acidotic, it will reabsorb bicarbonate and excrete hydrogen ions, and vice versa. So kidneys are very, very important and very, very necessary, and we can already see what's going to happen when the kidney starts to break. We lose our waste excretion abilities. We lose our blood pressure managing abilities. We lose our ability to listen to the brain and balance our fluid. We lose our ability to manage our acid-base balance. And unfortunately, we also end up hypocalcemic because one of our kidney jobs is vitamin D conversion. Without vitamin D, we don't absorb calcium. So, unfortunately, a lot of kidney patients, when they break, when the kidneys are broken and they're not doing their vitamin D job, a lot of kidney patients are hypocalcemic as well because we can't absorb calcium from the GI tract without vitamin D. And if the kidney can't convert vitamin D, we don't hold on to calcium. So we can see some of our recognized cues coming up here. The last thing the kidney does, so on top of waste, fluid balance, blood pressure management, acid-base balance, calcium absorption, and now we've got erythropoietin. Kidneys are very sensitive. That glomerulus senses a lot, and when it senses that it's not getting enough oxygen, it sends out another. So it's got two little hormones that it uses. The first one's renin, and it can help itself. It's got renin and prostaglandins to fix its blood pressure issues. And it also has erythropoietin, which will help itself fix its oxygen carrying issues. So it's like, wow, I'm not getting oxygen. It doesn't know what the lungs are doing. All it's going to say is, I'm not getting oxygen. I don't know what else is going on, but I'm going to do my part in fixing the problem by making the bone marrow produce more red blood cells, because I know if we have more red blood cells, I can get more oxygen. So I'm going to do my part. So whenever you're in a low oxygen carrying environment, you will get some stimulation to make red blood cells. Of course, it's going to take a little while to make some red blood cells, but at least it's trying. So anemic patients will have erythropoietin stimulated by the kidney. So we can imagine when the kidney is broken and not doing its job, it cannot excrete erythropoietin, and we cannot get our stimulus for increased red blood cells, making you anemic. So we can kind of already see some problems that are coming from a broken kidney just because it can't do its normal jobs. Renal vocabulary, I don't think there is anything unusual in this. Again, the reason you're studying the renal vocabulary and knowing these things is that I'm going to use these words in your test questions, and I would need you to know what they mean. I can't answer your questions and during the exam to tell you what certain things mean, so I will try to put a little vocabulary in the anatomy and physiology section. One of the things I do want to point out is that anuric and oliguric, meaning no urine and some urine, those have specific definitions put out by the Kidney Association. And anuria means scant or no urine output. So it doesn't mean you're not making anything. It just means you're making less than 50 milliliters a day. So anuric patients can still dribble urine, but it's just less than 50 milliliters a day. Oliguria, meaning low urine output or reduced urine output, also has a definition, and that is less than 0.5 milliliters per kilogram per hour. I know everyone's heard 30 milliliters an hour is normal for an adult. Well, that number started getting people in trouble because it really turns out that there's a huge difference between an 100-pound 60-year-old lady and a 300-pound 6'5" linebacker. They make different amounts of urine. 30 milliliters an hour does not cover everybody. So they changed, the American Kidney Association and Kidney Docs World Round got together and decided that adequate urine output or less than adequate urine output is going to be weight-based. So for a patient that weighs 100 kilos, which is about 200 pounds, 100 kilos, they should be making 50 milliliters an hour of urine. If you weigh 50 kilos or you're a kid, 25 milliliters an hour is fine for you. You have less circulating blood volume, and so you're going to make less urine. So that number we are going to repeat over and over and over again for oliguria. Normal and adequate urine output 30 is a nice round number to remember and very easy to remember, but it really is weight-based. So a 100-kilo person is going to make different urine than a 50-kilo person. What else do we got? The lab work on the kidneys. Blood urea, nitrogen, and creatinine, those are both waste products, okay? They're waste products from the breakdown of proteins and muscle activity. They are acidic. They're bad. We don't want them circulating. But they do circulate because constantly work's always being done. There's always some waste being carried to the kidney. So that's our normal BUN and creatinine is just normal waste being carried around to the kidney. If you're working out and you're lifting weights, your BUN and creatinine are probably on the higher side than other people because you're just creating more breakdown products. If you're sick, if you're a fever, you're high metabolic for whatever reason, your blood urea, nitrogen, and creatinine might be higher because you just got a lot going on in your body. Whereas if you're sedentary and not doing anything, your waste product levels are going to be lower. So there's quite a range on your normals. But what we don't really worry about lower than normal. You're probably just not doing a whole heck of a lot. But higher than normals mean that the kidney's not getting rid of waste products like it should. Glomerular filtration rate, we only worry about that with chronic kidney disease. It's only used to stage chronic kidney disease. We don't really look at it for acute problems. The electrolyte levels, it's just there to remind you that those are important. And a creatinine clearance, if you do see that ordered, that is a 24-hour urine collection, just because blood urea and nitrogen creatinine is like just a snapshot of time. A 24-hour urine collection will give them a much more detailed view of what's going on with what your body produces in 24 hours and what you excrete. A urinalysis, I want you to know what's normal to have in your urine and what's abnormal to have in your urine. We should not be dumping protein or glucose. The body needs that for essential functions. The only time you dump protein and glucose is when you overeat protein and glucose. If you eat more protein than you can handle, you will spill some of that out in your urine. If you go and you just eat 15 birthday cakes or go to Krispy Kreme and eat 3 dozen donuts, you're gonna spill some glucose because you just overloaded your body with it. Some of it is legitimately waste. But normally we hold on to all our protein and glucose because that is our body's building blocks. Ketones are a waste product of metabolism, and usually we don't find that in urine at all, unless for some reason the only time it is normal to find ketones in your urine is if you are basically if you're ketotic, and the only reason you should be ketotic is if you're on a keto diet. The reason you're on a keto diet is because you're not using any carbs. You don't eat any carbs. You have no carbs in your body, so your body has to make energy another way. The body wants to make energy with carbs. That's its preferred choice. It's the cleaner version. It's kind of like electric energy versus coal energy. The body wants to make, and its cleanest way to make energy is with glucose. And if you don't give your body glucose, then it's going to make energy another way, which is kind of messier and provides a lot more waste products. So when you just eat protein and you don't provide yourself carbs, you're going ketotic because you are really making energy another way by burning fat. And that is messier and has a lot of smoky remnants, which are ketones, and the body will get rid of those. So the only way that it's normal to spill ketones is being on a ketone diet. Otherwise, it's a sign that something is going wrong and you are breaking down fat and stores that you shouldn't otherwise use. You shouldn't have blood in your urine. We should save all of our red blood cells. We shouldn't even be excreting those out into the filtrate in the first place. So, like I said, protein and glucose shouldn't be there. Ketones shouldn't be there unless for some reason you are modifying your diet to over-exceed those. Blood should never be there. The presence of blood in the urine means that something is broken along the track and red blood cells are leaking into your filtrate. They shouldn't be in the filtrate in the first place. Specific gravity is just a reading of concentration. A high concentration means that there's a lot of solutes and not a lot of water, so we consider that the kind of dark concentrated urine. And low specific gravity is very watery, very diluted urine, the clear to pale yellow urine. Like I said, red blood cells shouldn't be there. White blood cells shouldn't be there either. They are only get out of the bloodstream and go into the urinary tract when there is an infection. Bacteria shouldn't be there. And casts are basically just pieces of junk and debris from cleanup processes in the urinary tract. So when you have casts, red blood cells, white blood cells, there's probably damage somewhere along your urinary tract from your kidney down to your urethra. There's no real way to tell from a urinalysis. Oh, bladder scanner. I love bladder scanner as part of the assessment. Please, if you go to a hospital, ask them where their bladder scanner is. You can always tell by the number of names how important an item is to nurses. You don't need an order to do a bladder scan. It's an ultrasound of the bladder, and it tells you very quickly whether there is something in your bladder or not. So when your patient hasn't peed for a couple of hours, we kind of want to assess the bladder to see, all right, is the kidney making urine? And it's just going to the bladder and storing, and we're not seeing it come out, or is the kidney not making urine? It's really a quick first step to figure out what's going on. If your patient hasn't peed in 8 hours and you bladder scan them and there's nothing in there, did the kidney even make anything? Because it should be being dropped out into the bladder as soon as it's made. So it's a really quick indicator of kidney function even before you draw labs. what is going on with your bladder. If there's a liter in your bladder and it hasn't come out, then there's something that needs to be dumped out of your bladder. So it's just a nice way to figure out, are the kidneys working without doing anything invasive? So that's a quick run through the anatomy and physiology. You can listen to the other voiceovers for the actual problems with the urinary tract.